Well, hello, good morning. This is Joanne Geer again. I am the Executive Director of the Biopharma Research Council, and we are an association for scientists across all the many silos of biomedical research. We have a wonderful mission. Our mission is to bring researchers together across all the different silos, industry, academia, nonprofit, government, suppliers, and those who love them. And we do this and just to stimulate collaboration. Right? We don't take a role in the ongoing collaboration. We just want to set the scene and invite people to come together. This is a general sampling of some of the activities that we've done in the past year, all of which are going to be repeated again this year. We are doing, I'll just mention a couple, we're doing the Internet of Medical Things, and our focus this year is on cybersecurity for connected devices, and that's going to be in Princeton in July. I won't go any further than that. Everything's on our website, and we'll be happy to bring you in as a speaker, sponsor, participant, attendee for any of the programs. We will continue to do many different webinars as well, of course. Today we're going to hear from Bob Gold on the science of motivating action for the mobile patient. Bob Gold is one of the world's leading behavioral technologists with more than 20 years of applied research and development experience in the growing field of digital to human persuasion and motivation. He applies his methodologies and techniques to help create a more sustainable healthcare infrastructure for hospitals, health systems and providers, pharmaceutical companies, and insurers as more patients need to be treated and engaged in their day-to-day lifestyle. He is especially focused on remote care coordination, pre- and post-discharge, and telehealth, with growing success in the management of both chronic conditions and episodic pre- and post-discharge management. Please feel free to add questions through the dashboard at any time. I'll be keeping an eye on them. After Bob speaks, then we'll have a nice long discussion and Q&A, so I encourage you to enter any questions. If they refer to a particular slide, it's helpful if you mention the slide, but no problem. And they could be comments as well. Bob, I'm going to hand things over to you now.
Thank you, Joanne.
Well, thank you.
Okay, everybody, I'm Bob Gold. Thank you for participating. And in today's session is going to be maybe a little different than you used to. It's on the science of human engagement, and I've been doing that for over 20 years. And in webinars, I tend to show a lot of slides to keep people on their toes and move rather quickly through them. So away we go. And what we're going to be talking about is a lot of the changes that are developing in healthcare, and how does that integrate with the science of molecule and biopharma development? How does that intersect with everyday lifestyle behaviors and technology? And there's an emerging form of research that's going to need to happen within biopharma, a lot more comparative effective research, and we'll cover that within the context of what we're doing in this. So what I do is for 20 years is been developing what I call behavioral RX, and it's a science, it's methods, and it's actually a system that uses psychological, behavioral, and some cognitive techniques to get people to build trust, credibility, and reciprocity to motivate action. So if you want them to come to a wellness appointment, if you want them not to go to the emergency room, if you want them to be more adherent to their medicine and those types of things, that's what the science is about. And it's really becoming a core component of things you'll hear about from the National Institute of Health, the Center of Medicare, Medicaid, and it's really becoming essential as people are aging in place, and more care coordination is done outside the four walls of a hospital, clinic, or provider office. So we moved a few years ago from becoming a nice-to-have science to a core componentry of how you care for people. So what I'm going to do today is I'm going to walk you through some of the major changes that I think are happening in health that affect how life science companies go to market, and that starts with the research and development process. I'll tell you a little bit about me as a prelude to getting into a little bit more insights into the science and methods we use to engage people for care coordination. I'll give you two quick use cases just to give you a feel. We'll have some closing remarks, and then hopefully we'll have plenty of time for Q&A. So I'm only going to be able to, in the 20 minutes you're going to share this journey with me, kind of cover the highlights of what we do. So here we go. Okay, so what are some of the drivers that make what I'm talking about, the science of human engagement, key to biopharma? Well, as everyone knows who in the last few years, the business of healthcare from a provider, hospital, payer, government-supported healthcare is changing significantly. There's different new players, federally qualified health centers, ACOs, all different types of care models are emerging, and there's clearly a shift to incentive and value-based payments. And this is coming at a time when life sciences companies are looking to get into personalized medicine, but the issue is personalized medicine is more than just personalizing a formulary for a pill in the moment. It's all about personalizing the entire experience for the consumer so that there's a higher return on investment to all the stakeholders, and we'll get into that. And then there's what I call the pill plus strategy, and you see there's certain pharmaceutical companies now disrupting the supply and demand chain by opening up their own online pharmacy and having more direct consumer engagement, because they realize in order to participate and have their drugs and treatments more effectively utilized, they need to have more of an engagement and better evidence-based information so they know how to participate in these risk-adjusted reimbursement and payment models in order to realize the return on investment for their R&D. So the way that we see the research happening and the information that pharmaceutical companies need to provide will be changing in this sort of comparative effective research paradigm, where there's a responsibility to show how consumers, patients, providers in different situation analysis, the effect of the whole treatment program, including the medication adherence. And how do you compare and contrast different environments with people in their lifestyle, at work, at home, at play every day. And if you can demonstrate situations that you can provide to the stakeholders that cause more adherence to your treatment or your drug, you're more likely to be used in the marketplace. So what we do is the human engagement piece of that. That needs to come front and center, more so that science than just the science of typical drug development. So my background, real quick, is that I'm a behavioral technologist, so I have 22 years research and development on digital to human motivation and persuasion, both behaviorally and cognitively. So how do humans trust each other, find each other credible, are loyal to each other, and how do humans react to technology? So whether it's helping, let's say, the Marines with a pilot, do they believe what the helicopter is telling it in the middle of a war, or do you believe an app or a wearable you have on your wrist versus a human telling you something? And what are all the behavioral and cognitive attributes of those human factors that get someone to believe something so they're willing to listen and act? And that's my background, and I started that in non-healthcare, and for the last 7 years or so have been applying it to healthcare. And then what the company I work in has done is taken that science and built out a system that's used by a lot of hospitals, payers, and some pharmaceutical companies to better affect care coordination in the marketplace and get back better based data about the outcomes within people's lifestyle who are using different drugs and treatment programs. So, having said that, let's share some deeper points about the science and what we do. But before we do that, I kind of just covered what's happening within life science, where the whole business of healthcare is shifting to an incentive-based performance model, okay? What has happened the last 5 years in the world that is causing even more disruption to what's happening in life sciences and healthcare. So I'm not going to cover this, but we all know that a lot's happening, and I could tell you behaviorally and cognitively, people's ability to absorb all the things that are thrown at them is not at the pace that the information is hitting them. So it tends to be, when you're looking at what should someone do around their health care, it becomes very confusing. Where in the old model, it's what the provider told you to do, you did, or you at least tried to do, or you didn't do, but that was the only one telling you what to do. Now it's not the case. And everything's 24/7, and there's really a lack of controls, and information is pervasive. So that means information about where people go to look for things and how many viewpoints they get is all over the map. So as a brand, as a biopharma company, the ability to have people listen to you and even believe in what you're saying is not easy and not what it used to be. And one other interesting behavior that has emerged with the emergence of social media, Facebook, Twitter, all those things from a behavioral standpoint, is there's no sympathy or empathy for gaps. So it's a world of ADD. So people expect instantaneous interactions. So while years ago you can provide content and put it up somewhere on a portal or email or print, people want to know things now, and they want you to figure out how to interact with them now. But how do you scale that? You can't have thousands of clinicians sitting at a call center. So how do you use technology actually to accomplish that and provide that no gap distribution of information in a way that is consistent with people's lifestyle? And that's what we're going to talk about here. So really, from my perspective, much of the technology deployed within the pharma med device area is not deployed in the best way. It's not focused on how humans live their life. It's focused around a set of technologies. We build an app, we send an email, those types of things. But it really doesn't help someone throughout their day. Like for people listening to me, they're listening to me right now. Maybe someone just broke out in a rash. What should they do? They're at work, they're driving, they're in different places, they're at dinner. And the idea from a corporate perspective is to build a brand that builds a bond to get people to actually want to listen, learn, and act and reciprocate. So if you ask a human to take your pill, it will actually reciprocate. Or you help a human to learn more about their disease state, they will actually take the time. Too many pharma companies relegate that science just to marketing and their agencies, and they produce this great material for physicians and consumers, but they really miss the point, which you'll see in a little bit. If someone's not willing to listen, doesn't believe, not willing to learn, and you're not giving it to them within their lifestyle, the content's secondary because they're not getting to the content, right? So that's what we're talking about today. And to start out with one little example to kind of bring this home now, we're starting to get a little bit more specific. One of the behavioral attributes that actually is a contributing factor to what you do every day and what you're willing to do and what you're willing to read or listen to or act on is your outlook. And this is the context for populations you may serve from a population health management perspective. And this is going to be one a little bit on someone who gets cancer. But interestingly enough, one of the studies that you do in human engagement is personal brand. So you've all probably been to sessions and talked about your company brand, but we all have brands too. Everyone on this call has a brand. You know, what do you think your brand is? What does your husband, wife, daughter, co-workers think of your brand, right? And what do you stand for? What are your fears and wants? What's your vision, desire, and objectives? All that, your personal brands adds up to what you care about and what you're willing to do and listen to and act on, right? And this has everything to do with adherence to a clinical protocol. Okay, boom, you see the middle panel. Now all of us on the call have melanoma. Okay, 2 seconds ago we did not. Now we have melanoma. So who do you think you are now? What's your tolerance for risk? What do you stand for? What's your perspective? What's the meaning of time? So if I'm on a drug or treatment for this, what am I willing to do and listen to and care about, right? And it doesn't matter how good people perceive in pharmaceuticals that their content is, if you don't understand this and how to get to someone, they're not going to follow what a provider, a payer, a pharmaceutical company wants them to do in their daily lifestyle. So the thesis here is that the science and method on how we engage a person is as important to personalized medicine and adherence as the drug itself and its associated content, right? And that's what I've been working on for many years, and it actually has proven out in dozens and dozens and dozens of cases. So let's get a little bit deeper, and due to the lack of time here too, I'm just going to share a model with you that we use in many cases. But one of the attributes we try to affect is resiliency, right? And it's a wonderful thing to affect because we all know, like me, I say I'm going to go to the gym every day and eat better, and I can't even be resilient to that. And I luckily don't have a lot of particular health issues. So someone who has health issues, to get them resilient to things, you know, maybe they getting divorced, they lost their job, they don't have a great outlook, do they believe in themselves, do they believe in others? So anyway, we have certain formulas and algorithms to affect resiliency, and if we could affect resiliency, it means you'll take your drug longer, you'll refill longer, you'll be more resilient to other aspects of a treatment protocol, right? So again, you can see this is more important than, is my image on my web page nice and is the wording in 5th grade English, right? This is, you're getting to the crux of some of this. So we're not going to spend time delving deep into the formulas, but suffice it to say, depending on the outcome of particular situations, there are behavioral attributes in which we try to affect in the science. Now let's show this, how this applies, and I'm just going to go over quickly a little bit about 2 use cases, and I'm going to try to just simplify it for purposes of time for the call. But this is an example. We happen to do a lot of work in Medicaid. So this is an example where a lot of Medicaid plans in a state have a lot of high-risk pregnant women. So a lot of them, for each nurse caseworker, they may have 200 to 300 cases they're dealing with. So typically they can't get to know people. They can't understand how they want to be communicated to, what's best, whether they feel they could follow a care plan, cannot follow a care plan. So they tend to get them all the same material, and they engage them on a reactive basis if they did an act like unnecessarily went to emergency room. And so it's not very effective, and it ends up being a frustrating experience for both sides. For the nurse, caseworker, it's frustrating because they don't feel they're doing a good job, and certainly for the consumer, the woman who's pregnant doesn't feel like they're being personally addressed. So we actually have a way of asking a few questions about how do you feel about your ability to follow a care plan, do you have support, a couple other lifestyle questions, and we could actually better categorize your whole risk, not just assign you risk based on your medical condition, and then we actually could adjust, the system adjusts how it talks to you in a digital conversation, in this case via text message with personalized links. So it actually will change its style, how often it talks to you, time of day, the questions it asks you, and it could actually triage answers in the moment. And if it feels you're going to do something that's adverse, it has the ability to ping your nurse caseworker. But now that nurse caseworker could be having lunch while we're communicating to all 250 of her high-risk pregnant moms in a way that's talking with them, that they feel is giving out social cues that we really understand them. So when we ask them to go to the wellness appointment and do things like that, they do it more often. So these techniques have actually proven out very nicely, but it's very different than a one-size-fits-all, let's produce great content and send it to everybody. And I'm not going to get into it, but I just want the audience to know a little bit more about some of the attributes of the formula itself. A lot of people use trust and credibility in the same vein, and they're wholly different behaviorally, so I'm not going to cover them here. But note, if you get higher marks for trust and higher marks for credibility, you'll be more believable, and there'll be more reciprocity, as an example. And just to show you a clear-cut, interesting case, which to me represents, you know, a typical traditional way that even an advanced way that a pharma company would go after content is, this was in the 90s, and there was a group of people that really wanted to help children with pediatric asthma in about the age 5 to 10 age range. So what they did is they got children's authors, brilliant children authors and brilliant illustrators, and they produced this wonderful kids book. And if you saw it, it's beautiful, beautiful images, and it walked a kid through simply and nicely. And for the younger ones, the parents read the kid to the book, and for the older ones, they can read it. And I think the book actually won awards. Well, it turned out that the kids who read the book or were read the book actually decreased the self-efficacy, because what happened is, which the kids can't voice and adults typically wouldn't even know behaviorally, they didn't feel they can do what the kids in the book were doing, so they shrank from doing anything because they didn't believe, they didn't trust themselves, they didn't find themselves credible. Now, they weren't able to articulate that, and their parents didn't know, and their doctors didn't know, but they're actually doing less because they said, I just can't do it, so I'm not going to do anything. Well, what happened is the form of how the kids were told the story and the way it spoke to them, they changed, and voila, increased self-efficacy because the kids now believed they could perform the task, so they were performing more of it. So, and this uses a lot of the science, and some of the techniques that we put into the formulas from digital to human persuasion take into account some of these things. So when the program is going, it will use one or multiple of the techniques you see on the screen. So I'm not going to cover them with you, but the examples I just gave use some of these techniques in doing this. And one last example, which is interesting, I find interesting, this was to get kids, boys and girls, to take an HPV vaccine. And it used to just be girls, and now it's boys and girls, and it's age 12 to 18. And the reason why I like to use this example, because they're underage, so you couldn't communicate directly to them. No one's sick. You have to go 3 times in some spacing. So it's a hard thing to get people to do this. And what we did is we took one group and we sent them standard content and messaging and how typical companies do it. And then we applied some of our behavioral RX methods on the intervention group, and you can see the differences in the outcomes. Now, some learnings from that were part of our science and method is that we go to people. We don't expect them to go to places during their day. Like I always said, there's no sick pregnant mom with all conditions who's logging into a portal and providing information. So the more you ask someone to go to a portal or app or things like that, the less likely you'll get reciprocity. It has to be highly personalized. They have to feel it's like a one-on-one conversation. So there's techniques that we use to do that. And actually, our system actually acts on a null response. So if you missed an appointment or you didn't do something, to the extent that we could know that or guess that, we will actually communicate to you and ask you if you did not do something because we don't believe you did it, and it stays with you. So it's supportive, just like a caregiver would or a mom would. You know, it would stay with you. And the other big thing in content development, it needs to be snackable. People want to be helped with what they need to do in the moment. So we're used a lot of discharge instead of handing them mounds of paper about everything about they need to do post-discharge or pre-surgery. It has to be just helping them in the moment now. It's what we all want in life, a short communications, right? None of us like the long email. Well, either do people in these conditions. So this is a movie, Patch Adams, for those of you who ever saw it, with Robin Williams, and their big thing was you treat a disease, you win, you lose, you treat a person, I guarantee you win no matter the outcome. So the $1 million question for everyone on the line is, do you have a personalized medicine engagement science method and system for that accompanies, augments, and is complementary to the science of drug development, and also for the go-to-market initiatives? Or do you have a typical, there's the science of R&D, and then it goes to marketing, and marketing has a certain way of doing things well. And the thesis here is that these things need to come together better, and people in the biopharma industry not only need to have a science on molecule development, but on human engagement. And that's really the overview for today. For those of you who want to stay engaged, you can text news to that short code, 51684. And now we can take any questions and answers from the audience. Thank you for having me, and look forward to interacting with everyone.
Thank you, Bob. That was really, really helpful. I have a couple of questions, and we have some questions coming in, so I encourage everyone to go ahead and start entering your thoughts. Comments are welcome as well. So there are a few aspects that I haven't heard articulated the same way before, and I appreciate that, because I think there's a lot of the issues you're grappling with are fairly common, but you're looking at them in a new way. So the thing I'd like to ask you about, and this may or may not be happening now, but if you know where it's happening, I'd love to hear about it, and if not, if you think it is likely to happen. So here's the question. In drug development and device development and getting various new products approved, for example, you can't sell a drug if you don't know how to make it, right? And I'm wondering, do you see a moment when integration of these kinds of tools is going to be required in order to both make sure that patients are, and some sort of an adherence program is integral to the drug approval process, and also the data collection side in order to, immediately pick up negative experiences and such.
Yeah, so it's a great question. So here's what I see clearly happening. If you look at, let's say, payers and approved drugs and formularies, and let's say generics are the top because of the cost, and then a branded drug tries to be tier 2 or maybe relegated to tier 3, what you're going to see happen is a more integrated approach with new guidelines from the Center of Medicaid and Medicare saying that, hey, companies, if you can show us from doing CER, comparative analysis, that you not only have a drug, but you have a model, an engagement model that can get people to stay on that and use that, and that can reduce costs and increase efficacy and reduce unnecessary readmissions, I think things may shift to where that drug could actually be tier 1, because if you look at the cost differential between a generic and the brand drug is nothing if you save a couple ER visits, right, that are unnecessary, right, or readmissions that are unnecessary. So I think there's going to be more of a intersection between dealing with the pure medical issue and dealing with the behavioral aspects of a person. And yes, so then I think that will affect how a device company or a drug company needs to present its evidence and its findings. And those who start doing that now, I could tell you from sitting at executive meetings of our clients on the health side, that would be a well-received and needed addition and would get their drug or device maybe a little bit ahead of the others.
Interesting. So it's not so much the regulatory side, but it's the payer side that is more likely to demand or incentivize using these tools. That's interesting. Are you working with anything that's in clinical trials, or have you?
Yeah, so our system is used in hundreds and hundreds of cases by millions of people every day, and we're participating in a number of research programs as we speak, but clinical trials would be sort of the whole genre of my talk, was that to move up the use of this research into a clinical trial. So when you produce the clinical trial results and data, you can have a comparative effective research about different situations and the science of the engagement with the drug, right? So, and I think you're going to actually start to see some of that be almost a requirement, not necessarily from the FDA, but from the ability to get reimbursed at a higher level, from the ability to get your drug moved up a tier. Yeah. So I definitely see a big use in clinical trials for this type of approach. Plus, it helps, let's face it, it's hard to recruit the doctors to do clinical trials. If our system is assisting the doctor in collecting information and engaging and doing this, it's a better experience for all the stakeholders in that trial.
Good. I have one more question, and then we have several that are coming in from our audience. You used a term that I hadn't heard before, which is snackable, and I think that's a really interesting. I understand what it means, and I think it makes a lot of sense. I know we struggle. We have lots of content we want to share, but everybody's looking at it on their phones, and how do we boil it down so that works? So my question is, can you talk about not so much the snackable piece, because I think we kind of get what that means, but I would like to hear more about developing messages that are forgiving and supportive, and how you're finding, how you have your understanding that that's what builds trust and credibility, or the way in which that fits.
Okay, so let me give you a couple examples. Real life examples. So with one client who happened to be a payer, but they were engaged in managed long-term care And now with the whole new model, they need to keep all their costs down of their staff and medical costs. So what we did is we built an algorithm. We discovered that certain claims for a lot of these unnecessary codes would happen submitted by the provider to the payer within 48 hours. So what we're able to do is we access the system, and on the 49th hour, if certain things happen or didn't happen, like let's say on the other side they were supposed to have a wellness appointment and it didn't happen, we didn't get a claim for that, we would ping you and say, hey Joanne, we understand you may have missed your appointment, is that right? And then you would say yes. Oh, well, here's 3 dates, would you like to reschedule, or I could put you in touch and do this. So we actually stayed with people when they didn't do what they were supposed to do. And then if they did something they weren't supposed to do, they were talked to in a whole different way and said, you know, you could have done these other choices. Here's things for you. We'd like you to experience this. And by the way, just in our system, if we ask you a question, let's say we need your weight every day and we need to stick it back in the EMR. So we go to you. We don't send you an email that says, go to your, click here, go to your portal. You're just not doing it. So we just get your weight, we stick it in your EMR, but if we don't get it, our system automatically, based on a few factors, will wait a set period of time and ask you the question in a different way, right? In a wholly different way, but we'll come at it differently. And you'd be shocked at how you engage someone, the social cues you give off significantly affect people responding. So those are just some examples of how we do some of that.
Interesting. And so I have one more question before I ask everybody else's questions. Is that I understand you're working with hospital systems and so on. What's the sort of the smallest cohort that you're working with?
You mean in terms of the size of the population?
To give our audience a sense of, like, is this something that makes sense if somebody is developing an app, they should, you know, bring you into the process, or if they are working with healthcare groups, you know, what's the smallest entity that makes sense for you to be working with?
Yeah, so we're doing, so by the way, answer those two questions. A lot of what we do, the methods, the algorithm, the science, could be embedded within existing programs. So like for certain healthcare organizations who have an app for some things, our engagement is embedded within that, right? So you can take components of what we do and embed it in different forms of communications, or you can use us as a whole to do that. Now, in terms of size, for example, we're working with some leading physicians at university health centers, and we're doing sort of cohorts or populations of 50 to 250 people. So we're doing one that's fascinating, that people who became addicted to opiates for severe pain management and now have severe behavioral health issues. And one of the forgiving and supportive things we do is to give those people a feeling like they have some influence in their care coordination. So at any point in time, they're on a certain regimen from us, but at any point in time, let's say they're going into a low or they're experiencing certain problems, they text a certain keyword. And since we know who they are, they're telling us something's happening to me. We react to that and go into a whole different triage mode. And that's wonderful behaviorally, because if someone feels they have some control over a scary topic and they can influence how they're talked to and engaged, they're 5 times actually more likely to listen. So that's a clear example where they're on a regimen, but they could interrupt it in any moment in time.
Very interesting. So we've had, so I am going to start asking questions from our audience now. So we've had some discussion about how payers are thinking about integrating these approaches. And this question takes a little different direction. Do you see wide use in future for mobile medication therapeutic management technology offered by pharmaceutical companies or retail dispensers themselves?
Okay. Yeah, so I could tell you, I can't tell you the pharma companies. We're engaged with about a half a dozen now in two ways. One is there are pharma companies who are taking the clinical protocols from them and their KOLs, their key opinion leaders, and we're putting it into our concierge care system, and they're providing it on a private label basis to thousands of providers who prescribe their drug as a way, as an educational tool, where providers couldn't figure this out on their own, but now they can do it, and our system is able to sound like it's coming from hundreds of different providers. So pharma companies are doing that with us now. The second is, as part of some of their community and education budgets, we're involved in a few research programs, one around pain, one around behavioral health, and one other I can't say right now. So pharma companies are just starting to utilize our services and understand it. So I see that happening more and more, whether that's a device company, a diagnostic, or a drug.
Thank you. Here we have another question. How is GOMO integrated with EHR systems?
Yeah, so basically two ways. We have standard interfaces for like HL7 and FHIR, which is the new way that EMRs interact. So we have those, and we also do a lot of batch secure FTP, batch file transfers between those two. So a lot of times, like from a hospital perspective, if there's 1,000 new or 50 new asthma patients they want us to communicate based on discharge today, they'll send us the file, and we'll gather information, we'll send the file back, or there could be a real-time web service. So I would say that that's a very tactical, solvable issue that we've done dozens and dozens of times, right? The key question is making what we do fit into the workflow of a hospital, their docs, their nurses, their social workers, their nutritionists, right? And that's what we're really good at. But yes, the tactical piece, we've interfaced to almost every type of system out there.
Great. Well, here's a question from a little different direction. What is the record for this methodology for those trying to keep off lost weight, the so-called rebound effect, where lost weight is often regained in about a year's time? Have you been used in that kind of a setting? The system been used?
Yeah. I mean, we haven't been extensively used strictly for weight loss. We've been used where weight was important to reduce as a comorbidity for a number of issues. And we are undergoing some interesting programs around weight loss, but I probably don't have enough data and enough time to answer that question properly. I'm happy to discuss it offline. It's interesting, the application of the science, so I've been working on this for 20-something years, maybe healthcare 7 years, the practicality of the infrastructure in the marketplace to do this is only over the last 3 to 4 years. So there's not necessarily a boatload of historical information, but it's just so intuitive and common sense, and it's working. But we don't have a lot of that history, right?
Mm-hmm. Okay. How does this approach affect the doctor-patient relationship? For example, who drives this relationship, the doctor or the patient?
Okay, I love that question, by the way. And, let me just give you some anecdotal story about that. And I could tell you this a zillion percent confidently. It's interesting because if you look in the medical community and say, okay, older physicians, doctors are more resistant to technology, and they feel you need a personal touch and technology dehumanizes the experience. Well, I could tell you unequivocally if you do the science that we suggest, not just creating an app or sending some messaging, email, text, if you do it this way, it actually increases the doctor's brand and relationship, because cognitively, if you're communicating to someone at home during their life and obviously only seeing the patient once a month or whenever it is, the patient doesn't differentiate that total engagement experience over time, and they actually have a more personal relationship with the doctor, and the voice in which the messaging speaks to you could sound like the doctor, and logically it's could be from the doctor. So so really it has the exact opposite effect, where the doctor could gain more control even when the doctor's playing golf or sleeping, right? So it actually has the exact opposite effect than people fear. It doesn't dehumanize, it further builds the brand behaviorally and cognitively.
Like that. That's an interesting sales line, right? Communicate while you're playing golf. I like that.
Yeah.
Okay, please comment on how this methodology may be used in remote telemedicine, which is as different from mobile device interaction.
Right. So, well, if telemedicine means, having a session, right, a video set, people mean different things by telemedicine, by the way, but let's just assume the question deals with telemedicine. I'm treating someone, right, on a video conversation or some type of online conversation, right? We're being used more and more in that scenario because we've integrated to nurse triage call centers. We're doing a program totally integrated with health coaching. So in other words, this diabetic program we're doing, the coach speaks to them twice a month. So let's just call that telemedicine, telehealth. But our system is basically communicating throughout the entire month, giving more information to make the session better with the coach. If the coach discovers something on the call, they could actually tweak by pushing a few buttons on their PC or tablet how the system engages the person, puts them in a different category or does something. So it actually, the key is, how do you blend human, in the case of telemedicine, how do you blend human and digital communications into one holistic system that engages the person, right? Because again, you can do it so behaviorally and cognitively they don't see the difference, but they see it as an entire engagement approach. So I would say it fits in nicely with that, and you're going to see more of that. And let me just say, there are now CPT codes that Medicaid, Medicare have put out that if you show electronic engagement as part of an overall treatment plan, you can get reimbursed for certain things, and that's increasing every day. We're working on adding an e-consult module because 3 months ago, CMS just approved reimbursement for e-consults for a lot of physical issues that they never approved before. So we're active in that community and be launching that very shortly.
It's like a virtual doctor visit in your home, huh? That's great.
Yeah, and by the way, that's like in countries that aren't as sophisticated, or at least from a CMS or FDA and this and that, like China and other places, there's a lot of, quote, telemedicine, telehealth going on every day. So the U.S. is sort of behind on that, and maybe for good reasons, but it's really going on globally.
Okay. Well, I have just one more question in the queue, but if anyone has anything to add, we'd be happy to take it. We may have kind of addressed this, but I'm going to go ahead and ask it because you may have some other thoughts. Patients who need long-term treatment often start off compliant, then lapse into frequent use, say over months or infrequent use, over, say, months or even years. What is the record of this methodology on keeping patients compliant over the long term?
Yeah, so again, I think I said it hasn't been used long enough to know, but suffice it to say, the goal and the science which we're producing is really designed to help people from a managed long-term care perspective, live their life more productively over time on chronic conditions. So I would say that in general, it acts as like a personal concierge to people, and it's helpful. And there are pockets of evidence that are propping up as to the effect of it. But if you look at the reverse side of to whoever asked a question, what are they doing about it now? And typically the methods and the costs are just high cost and not a lot of success. So to put something like this in place is scalable to millions of people because it doesn't require all types of special equipment, devices, this and that. So there's a lot of reasons that you can test, and you can test ABC. I can tweak the time of day, I can tweak the style, the tone, and I could see which I'm getting more effective use of. So you don't have to make all these Gestalt, decisions up front. So it actually helps you learn and get better at what you do.
That was my next question is that, I guess, does the messaging then evolve over a period of time in the course of, say, a year or something? Do people get inured to the messages and make them easier to ignore, or do you need to refresh them on a regular basis, or is that something that's already built into the system?
Yeah, so it's all of that, but like in the case I gave with the HPV, one of the things we learned, even though we had a lot of success, that we needed to tweak better how we talked to the 12-year-old girls and the 17-year-old boys, and we needed in general to better genderize the communications between boys and girls. So we got better over time by seeing how people responded or didn't respond. We tried things and it kept on getting better. So the point is, it's like playing a sport. You can't get better if you're not in it. If you're not understanding, if you're not understanding the science, and you're just having a few people create what you believe is great content, and you don't understand the science of engagement, you're never going to learn. You're never going to get better. You're going to throw stuff against the wall. We have very sophisticated hospitals that I could name, some of the top in the globe, that sit around and say, oh, should we give an incentive for the patients, a gift card this month? And, maybe the content wasn't in 5th grade reading. Should we change an image? And I'm sitting there saying, you guys have missed the whole point. You're so out of touch with the things you need to study and do on human engagement. You're never going to get better. So that's my plea to everyone. No matter how effective it is from day one, you got to get into the game of having some science that applies to this.
Well, I think we have a pretty good audience of scientists, so hopefully that's a resonant message. I think this interaction between the kind of study that you're doing of human response, and we have bioinformatics people online, we have drug development people, we have early stage researchers, and I think this is a really lovely thing. And I have one more question/request for a comment here. Let's see. There's been a lot of research over the last 20 years, especially in the UK, on concordance rather than adherence to health recommendation, in which doctor and patient act as a team to plan their care regimen and how to optimize the patient's ability to carry it out. The concept of who is driving and who is in control may not be the optimal way to secure engagement. Please comment.
Okay, so, there's perceived control, and let's call it perceived, and then does a person feel that you identify with them? In either direction, Dr. But do you feel invested in the process? Do you feel like you could influence the process? So the ability for both sides to feel and perceive that there's a collaboration around how you're being engaged could only help. So like an example, what we do is when we onboard people, we assess, and we're working with the provider community, we may ask some questions that totally the providers never even thought of about people's favorite genre or this or that, other things, and we incorporate some of that into the personalization. So it feels like the communication is understanding who you are as a being. So when it gets down to very specific medical issues, there's more reciprocity. So I would say the answer to the question about control is the people who are doing that need to understand how to get people to feel like they have more influence and are more invested and have a little bit more control over their life, whether they do or not, right? And that's the art and science of what we talked about today. And there are definitely techniques to do that that are extremely, extremely effective, where the provider could get people to do more of what they want, but the person actually feels they had more influence on it, right? So they're not mutually exclusive, by the way. That's the point.
That sounds like good parenting to me.
Yep. In a way it is. In a way it is, right?
Yeah,
you don't treat all your kids the same way, right? You can't talk to all, if you have 3 kids and they're wholly different, it would be absurd if you just treated them all the same way. Well, that's what we do in healthcare. That's what pharmaceuticals do, right? That's how they do it. It's absurd, and if you think about it.
Well, on that cheerful note, thank you so much, Bob. If you have any sort of concluding comments you would like to share, now's the right time to do that.
No, I'm good.
It hasn't come up yet. That should come up before we part.
No, it's just that it's a hard topic. Just everyone, it's a hard topic in one setting for a few minutes to get your arms around. Some of the information I shared may be counterintuitive to, what is going on. But I could tell you it's definitely an emerging science that's going to play more critically into the whole revenue reimbursement care coordination models, not only in the United States, but around the world. We're starting some projects in Ireland, and we're kicking off with our first hospital in Kenya for pregnant women. So this issue about there's not enough money in the system to sustain how we're delivering care coordination to people, especially with chronic long-term conditions. So a lot of governments are out of money, and what do? So it's forcing new models and new ways of thinking, and that's what we need here. That's my ending comment.
Thank you so much. Well, I want to thank everyone who has joined us today, and almost all of our programs that come from ideas suggested by our community. The slide you see up here is the way that you can get in touch with Bob, and I'm going to leave that there. And you'll be receiving email from us, and any further comments, any thoughts that this is a topic you'd like to see more of, or other topics you'd like to suggest, we'd be very, very happy to hear from you. I want to thank everyone for coming, and have a good day.